Okay, why don't we go ahead and kick off, yeah? So good morning, everybody. Welcome to Fetal Hemoglobin and Sickle Cell Disease Hydroxyurea and beyond. My name is Sanjeev Wadhwani. I am the chair of the board of directors for SCAGO and lead the research committee as well as work at GBT. So very pleased to be here and to welcome all of you to this special simultaneous session. It's my pleasure to introduce Dr. Robert Klaasen, who will give this presentation. And we agreed that if there are any questions, certainly put them in the chat and we can, or just raise your hand and we can, let's say, even patch you in live for any questions. And of course, have a Q&A at the end of the presentation. Just a couple house rules before we begin, just to make things, let's say, efficient. One, there is an interpretation button that you should have at the bottom of your screen if you'd like to listen to the presentation and discussion in French. We kindly are supported by one of our interpreters, Hamid, who will help with that. And then, as I mentioned, for any Q&A, please put them in the chat and we can tee them up during the session as well. So looking forward to this presentation, and I'd love to turn over to Dr. Klaasen.
Thank you, Sanjeev. Thank you for that introduction. And I'm very pleased to give this talk. And I'm very excited about this conference. There's been quite. I was looking at the agenda is very interesting agenda, and I got to admit I'm very happy that people actually came to hear my talk, because I saw the competing talks and they sounded very interesting. So thank you for coming in to learn a bit more about fetal hemoglobin. I think this is probably the nerdy group, or people who like to deep dive into what goes on. So I think this should hopefully be useful.
Dr. Klaasen, sorry, just to interrupt. I think it's also, I wanted to also do an introduction for you. So I think that would also be good to position where you are placed for that. So bear with me also.
Oh, no problem.
Go right ahead. As well. So Dr. Klaasen is a pediatric hematologist, oncologist, and the program leader of the hematology program at the Children's Hospital of Eastern Ontario, as well as a full professor at the University of Ottawa. Dr. Klaasen has always been a strong advocate for patients with hemoglobinopathies. He's a founding member of the Canadian Hemoglobinopathies Association. He has successfully co-chaired 3 conferences focusing on hemoglobinopathies, including the first National Canadian Sickle Cell Conference. In 2005, he actively lobbied the Ontario government to include hemoglobinopathies in the expansion of the newborn screening program. He's also the lead owner and inventor of the quality of life measurement tool for thalassemia called the TranQual, which has been used in numerous multi-center clinical drug trials for patients with thalassemia. So with that, I'll officially transition to Dr. Klaasen.
Thanks.
Thank you.
That's very kind of you. Thank you. So as I was saying, this talk is going to be, I purposely didn't put in a lot of slides because I do think it's a fairly complicated topic, and I'm hopefully going to try to explain this in a way that's understandable. But please don't hesitate to ask questions, and I'm looking forward to that. As I say, I purposely left lots of space for questions because I think that'll be coming. Et pour ceux qui parlent français, je peux répondre en français. Il n'y a aucun problème avec ça, mais sinon, pour que les choses soient plus simples, on va présenter en anglais. Okay. Thanks, everybody. So the first, just an overview, we're going to go through sickle cell disease. I think it's important to kind of get an understanding of, I think most of you people attending understand what sickle cell disease is, but I think it'd be helpful to kind of tie in where does fetal hemoglobin fit in with that. Then we're going to obviously spend a fair bit of time on hydroxyurea, which many of you know about hydroxyurea, but we're going to see how, particularly talk about the link with fetal hemoglobin. And then I'm going to briefly talk about gene therapy, because I do think that's obviously the future down the road. And it does really link in with this topic about increased fetal hemoglobin. And then I go to the conclusion. Oops, wrong way. So I think everybody knows we start off with a nice, so this is what a red blood cell looks like. So it's a nice donut shape that doesn't go all the way through, but it looks like a donut. And it's basically a bag full of hemoglobin. And I'm going to talk more about hemoglobin. And then what happens in sickle cell disease is those nice flexible donuts change into these more rigid sickle cells. So this is a very flexible thing that can kind of worm its way through the blood vessels nice and easily, whereas the sickle cell is more rigid and gets stuck and causes damage as it goes through. So again, just to remind you, this red blood cell is just basically a bag full of hemoglobin. So you say, well, what is hemoglobin? My doctors talk about hemoglobin all the time. What actually is it? So this is a cartoon of what it shows like. And so it's made of two components. So heme, which is this component right here, and then the rest. So there's 4 heme components, and then there's 4 globin components, and that's where it gets hemoglobin. So it actually makes sense. And there's 2 beta globins and there's 2 alpha globins. And sorry, it's getting technical, but you'll find that this actually pays off in the end. So hang in with me. And sickle cell disease is a single amino acid change. So these curly things are just a bunch of amino acids in a row. And sickle cell disease is on amino acid number 6 is a substitution, which changes the beta globin, specifically the beta globin. That's kind of important for later, to make it sticky. So just by changing one tiny little change, you've made this thing that normally is suspended in a bag, and you made it sticky and it sticks together. So what happens is that it sticks together in these pairs. You see how it kind of one sticks to the other, and you get these, you get 1, 2, 3, 4, 5, 6, 7 pairs in a row, and they form these, what's called polymers. So they stick together and then form long sticks. They just kind of pile up on each other. So instead of floating around nicely in the inside the red cell, doing its job, it gets stuck together and forming these long poles. And these long poles, that's what changes this cell from the, remember, as you got the donut shape to the sickle shape. And it becomes very rigid, and as I say, tends to block the blood vessels. So as I mentioned, you know, the whole, here, just going back a bit. Yeah, here we go. Let's go back. So these heme groups, their job is to bind oxygen. So you take a big breath in, you breathe in oxygen, the oxygen goes into your bloodstream and binds to this heme group, okay? Then it goes in, so here you have so you've breathed in, you've got the oxygen in the red cell bound to that hemoglobin, and then it's delivered to your finger or your toe or your head. But if you have this distortion and you get blocking up the blood vessels, then the oxygen doesn't get to where it's supposed to be. So that's what causes all the problems in sickle cell disease, is basically small blood vessels being damaged and a lack of blood flow to various parts in your body. And this is a cumulative thing that happens. So it can happen acutely in what they call crises, you know, with acute crises, but it can also happen gradually over time. And that's where the long-term damage from sickle cell disease can happen. And this is all because the hemoglobin, instead of just floating around nicely in the red cell, becomes sticky and sticks together and polymerizes. So what we want to do is stop this stickiness and stop forming these long sticks of hemoglobin. So how do we do this? So this is a bit daunting. I'm sorry about this, but this is helpful. This is what is going on. So remember, I was telling you there's 4 of the hemoglobins. There's in an adult, and what I'm talking about is this hemoglobin A, which means hemoglobin adult. Okay, is alpha 2 and beta 2. Okay, so that's when you're an adult. And here I'll show you. So down here, this is weeks of life. So here, if you have, this is looking in the fetal life, and this is looking at the newborn life. So roughly after about 30 weeks of life, you end up with virtually all your hemoglobin being alpha and beta, or hemoglobin A. Okay, so that's what happens in their life. But if you look back, you see this this other one called gamma. And gamma is the one together with the alpha that makes hemoglobin F, the fetal hemoglobin. And this is the whole point of this talk. So I'm hope this is why it's so crucial, is we're talking about this fetal hemoglobin, which is the alpha and the gamma instead of the alpha and the beta. And remember, the sickle problem, the amino acid changes in the beta. It's not in the gamma. So the changes here are not in the beta. Fetal hemoglobin works beautifully well. There's slight differences from hemoglobin A, but there's many people who have it's sort of well described, people who have a condition called hereditary persistence of fetal hemoglobin, who have got very high fetal hemoglobin, and they live normal lives and they do fine. So you can actually function very well just with fetal hemoglobin. So I've got to admit, there is some differences, but I'm not sure why our body built in this changeover that we changed from fetal hemoglobin from hemoglobin F to hemoglobin beta, but it happens. And you can see it happens fairly early on. It happens around 12 weeks of life. So after about 3 months. So when a baby is a fetus inside its mother and it has sickle cell disease, no problem at all, no issues. Newborn, most of the blood in the newborn is about 80% of the blood in the newborn is fetal hemoglobin F. So newborns do not have any trouble. So we do not see any problems with babies who are born. We do screening at birth and we find babies who've got sickle cell disease right at birth, but we know we don't have to rush and do something because things are fine for the first few months of life. But then as you see, you can see that the gamma relentlessly drops, the gamma relentlessly drops down and the beta goes up. So this is the problem. If we didn't have this happening, sickle cell disease wouldn't be a problem because we just continue with fetal hemoglobin. So, and so I'm just showing the hemoglobin S is the alpha 2 with the beta with that S change in it, with the sickle change in it. That's kind of a long way, but this is a really kind of a crucial thing that I show all my trainees who they have a science background. So I'm hoping that it's not too sciencey, but it is kind of important. So this is actually this is an actual patient we follow in our clinic. Obviously the name has been removed, but so this was a baby. So here's the baby's date of birth. The baby was born in May of 2021. And at that time had about 85% fetal hemoglobin and had, roughly 15% sickle hemoglobin shortly after birth. And this is about a couple of weeks after birth. But you can see the fetal hemoglobin kept going down, 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 boom, whereas the sickle went up and up and up. So this is where the problems start happening. So then what we do is, for patients with the sickle, the S kind of sickle cell disease, we start this medicine called hydroxyurea. And I'm showing this is what has actually happened. We started the hydroxyurea and you can see almost immediately the fetal hemoglobin, rather than continuing the relentless trend downward, turns around, starts coming back up. And the sickle, instead of going upwards, turns around, starts coming back down. It doesn't totally reverse the problem, but it slows it down and makes it much better. So you can see this child at 1.5 years of age or 2 years of age has over 35% fetal hemoglobin, rather than what would normally be less than 5% or 2% fetal hemoglobin is up to 35%. And that means that the sickle is much lower. It's only about 65% instead of 90%. So this is real. I'm not, this is a baby that I'm following, and I just randomly picked one, and I show you this is what happens.
Dr. Klaasen,
yeah.
We have a question which I think would be, if you can go back one slide.
Sure.
Question is there any reason why hydroxyurea wouldn't be started earlier in this patient? Yeah.
Excellent question. So this study, and this comes from it was an important international study, or it's probably American, but study where they did it. It's called Baby Hugs, and a very cute name, but it's Baby Hugs, and it was a randomized trial of, and I'm going to talk a little bit more about it later, but it was a randomized trial of, and what I mean by randomized is that by flipping a coin, half of the babies were given hydroxyurea and half were given a sugar pill or what's called a placebo. And that study decided to start at 9 months. And I must say, I don't know exactly why they picked that particular thing. I think one of the reasons is it's very uncommon to see serious complications from sickle cell disease before that age. And because hydroxyurea, there hadn't been a lot of data of young children being on the hydroxyurea, I think they kind of erred on the side of caution and said, well, let's start at this age because we think it's safe. There's not a lot of problems with sickle cell disease before age of 9 months, and the child is a little bit older, so more of a safety question. But I think it's excellent, and it's a very good question. Maybe we should be starting earlier. Maybe we should be starting at 6 months. Would be, or even earlier. Why are we even waiting till it falls? Maybe we can start it right away. And I think that's something that certainly could be considered going forward. I don't know if anybody's actually looking at that, but it's something to consider. Yeah, so that's an excellent question. I agree. So hydroxyurea, this is a very old drug. It was first made in 1869, so it's more than 100, almost 150 years old, this medication. And you can see it's just a tiny little molecule. For those of you who understand what molecules are, this is a very simple, small molecule. And the N is nitrogen and hydrogen and oxygen. So it's nitrogen, hydrogen, oxygen, simple stuff in this very small molecule. And the good thing is that so there's good and bad to being so old. So because it's been around for such a long time, it's really cheap and it's very easy to make. But because it's been around and it's so cheap, no industry partner is really out there selling it. So it's harder to get studies done because there's no industry backer saying, oh, I want to get my drug out and sell it. So I'm going to fund these. Doing studies is very expensive. So, so like I say, the good news is that there's no industry behind this pushing this drug, and it's wonderfully cheap. But then the flip side is then there's no industry sort of sponsoring big, more studies with using this medication. And this is just pictures of blood smears of a patient with sickle cell disease without hydroxyurea, sort of what I showed you before, where you had the regular red blood cells and those sickled cells. You can see the sickled cells in the blood. You can see that. It started the hydroxyurea. There's less of the sickled blood. There's still a few. And then once you increase to maximum dose, you can see the sickled cells are gone. So that's why when you're with your doctors, we start at a low dose to make sure it's well tolerated. And then we increase the dose for this exact reason, because if you increase the dose, you can get rid of the few remaining, or there's much less of the sickled cells by doing a maximum dose. Okay. Right. Okay, good. So just hydroxyurea. So, and this kind of goes to the question that was asked earlier, which I think is, why didn't we start it earlier? There's always a bit of, any medication, you're always worried potentially about side effects. Hydroxyurea is no different. The good news is because it's been used for so long, we understand its side effects very well. And the main one, and which is probably the most annoying, I would say annoying thing for the families and for the physicians and for all the healthcare providers, is that it lowers the blood counts. So one of the cells it lowers is called the white blood cells, which are involved in fighting infection. So that's a bit worrisome. So you say, oh my gosh, this medication kind of affects your immune system. You could be more prone to infection. And I think initially that was one of the concerns, is could this make people more prone to infection? But the good news, and I'll show this later, is that the studies actually show that patients with sickle cell disease on hydroxyurea have less infections. Because their body is functioning better, they actually have less infections than those who are not on hydroxyurea. But we do need to monitor the white blood cells to make sure they don't go too low. So a little bit of a decrease is fine and doesn't cause any trouble. We just have to keep track to make sure it doesn't go too low because of the potential risk of infection. Now, that being said, I've been doing this for 22 years now. And hydroxyurea I've been using in my practice for 15 to 20 years. And it's a lot in the last 10 years. And I've not seen any very bad problems with low white blood cell count and serious infection. But I think that being said, we still want to keep track of it. So we do need to do blood work a bit more often than we would without being on hydroxyurea. Then there's also cells called platelets, which are the ones that stop the clotting, stop bleeding. So if you cut yourself and you do a cut on your finger, you're bleeding, first thing that stops it is these cells called platelets. So if they go too low, they can cause problems with potentially being at risk for bleeding. Again, especially as long as you monitor it, I have not seen that being a problem, but we do occasionally have to have some patients who have to adjust their dose because either their platelets or their white blood cell counts are low. On paper, there's supposed to be issues, stomach upset issues, nausea, vomiting, diarrhea. I have not seen that. We have, in my clinic, we follow 200 children with sickle cell disease, and almost 150 of them are on this medication, the hydroxyurea medicine, and that has not been a problem. So that's good news. You can get abnormal liver tests, and that's sort of a blood test looking at the liver. Most of the time that settles down. It tends to be not much of an issue. Occasionally skin rash. The one that you can see is darkening of the nails and the skin, and this is a good example here where you can have some changes on the nail. Whereas if you're not ready for it, I've had patients say to me, "What's going on, doctor?" And they say, "Unfortunately, that's one of the side effects of the medicine. Happens in about 10% of patients, but it's more of a cosmetic thing. It's not dangerous. It doesn't look, and also sort of part of that. Sometimes you get a bit thinning of the hair, but then that settles down after a while." Concerns about loss of appetite, but I find in actual fact, because their disease is better controlled, their appetite tends to be as good, if not better, on the hydroxyurea, and they certainly grow very well. Patients on it grow very well. So this was a study published a while back, but anyways, it followed 122 children for basically 4 years on average, and there's sort of longer studies, but I just kind of pulled this one out. And there was some problems with low white blood cell count, but there wasn't any problems with kidney or liver problems. There was no growing problems. There wasn't, and one of the concerns has been about leukemia, and there was no problems with leukemia or blood problems. And I said this skin change that we're talking about, the skin, it happened about 10%. There was 2 deaths from the sickle cell disease in this 122 children, but they weren't related to the medication. There's one infection, which you could potentially argue, but it was felt not to be related to the medication, and one reaction to a blood transfusion, which is not to do with that. And then one of the questions always has been with hydroxyurea, well, does it wear off? Like, does the effect wear off with time? But there's a very good study showing after more than 7 years, and I've certainly seen it in my practice, the fetal hemoglobin stays very high. The hemoglobin is higher. So remember I said the white blood cells and the platelets go lower, but the red blood cells go higher. You get more red blood cells. And but particularly the fetal hemoglobin is sustained for many, many years. And I've definitely seen that. And you have a decrease, and having the white blood cell count down a little bit is actually good. And bilirubin, which is the thing that makes you yellow, is less. So patients who are quite yellow become less yellow on the hydroxyurea. And this was that baby hug study that I was telling you about. This is again the babies who are, half of them were on the hydroxyurea and half on the sugar pill, the hydroxyurea. And so you look at the placebo is the blue, and the hydroxy, and it was British, so they call it hydroxycarbamide, but it's the same thing, just a different name. And that's the red. So you can see, and in that study, because it was the first time doing it, they actually kind of picked a lower dose of the hydroxyurea, just to be on the safe side. But even with the lower dose, you can see there was less pain. So each little tick, for those of you who aren't used to what's called a cumulative plots here, is that every tick is one patient who gets pain. So every time you get, so these are all the people who are getting pain over time, and you can say about half of the patients in that study And you can see these are the weeks. So 100 weeks, so 2 years, half of them did get pain, but there was 3/4 of them got pain in the placebo arm. And this is what's called chest crisis. So you can see roughly 5% got serious lung complications on the hydroxyurea, whereas on the sugar pill is like 15%. So there's a big difference in the placebo versus that. And same with, this is pain in the hands, hand swelling, and this is needing a blood transfusion, so there's less. And I just want to again qualify, this was a low, because they were just starting and they were more concerned, they used a conservative dose. This is not on the maximum dose. You remember how I was saying, when you get to maximum dose, you get less of the sickling. And then finally, I'm going to talk about, so that's hydroxyurea. So I'm hopefully convinced you that the benefits of the hydroxyurea certainly outweigh the manageable side effects. But the next thing, because it was hydroxyurea and beyond. So this is the beyond part of my talk. This is just recently published in our major at the annual meeting last year of the gene therapies that are being used in treating sickle cell disease. And this is the table on this. And I pulled this out to say, so there's basically 7 different ways people are doing gene therapy in sickle cell disease. And 4 of those 7 ways work by increasing fetal hemoglobin. Because the realization is fetal hemoglobin is a very important inhibitor of sickling, of that sticking together piece. It keeps them. So this is why there's a focus. My wife, who's a doctor, said to me, well, that doesn't make sense. Why would you, if you know sickle cell disease is simple. You've got this one amino acid that's changed. Why wouldn't you just fix the problem? And part of it is that in gene therapy, it's very hard to get at all the cells. You have a limit to how much you can get at. So to fix sickle cell disease itself, you'd have to really get at all the red blood cell making cells and change them all to get the sickle cell gone. The way this works is this gene editing and using things you may have heard in the press, that they're CRISPR-Cas9. What they're doing is they're actually going back to, and here I'm going to go backwards here just to this this slide. So what they're doing is what happens here, remember where we're changing this changeover from the fetal hemoglobin to the beta hemoglobin? It happens because there's a suppressor that turns off the gamma globin production. So it shuts this down. So what the gene therapy is trying to get rid of that inhibition and let it come back up, let the fetal hemoglobin come back up and become more, much more part of the red blood cell production. So that's how gene therapy is, they're doing it, is they're focusing in on increasing and you don't necessarily have to get all the cells to do that, to basically get rid of these things that are slowing down the fetal hemoglobin production, and basically so you enhance the production of fetal hemoglobin. So that's how these gene therapies are working. And again, there's lots, that's a whole separate talk talking about gene therapy, and I'm not an expert on gene therapy, but there's definitely a lot of promise in the area. There's a few concerns that have come up, but I think that's, it's certainly something way forward, but I just highlighting the importance of fetal hemoglobin going forward for treating sickle cell disease. So in conclusion, and then we'll get to, I see there's lots of questions. So in conclusion, sickle cell disease is an inherited disorder, disease of the globin, of the beta globin, that causes a change in the shape of the red cells. And the decrease in fetal hemoglobin and increase in sickle hemoglobin is when complications start occurring. So hydroxyurea is effective at increasing the fetal hemoglobin. I showed you with that one case that it went from very low to over 30% fetal hemoglobin. And the good thing is it has side effects, but they're manageable and we can deal with that. And gene therapy to increase fetal hemoglobin is on the horizon. So that's kind of the way forward. Okay, I'll get to questions. And Sanjeev, you want to? maybe read them out, that would be great.
Yeah, super. No, thank you, Dr. Klaasen, for a great presentation on fetal hemoglobin and on the link to therapeutic options or therapeutic approaches, as well as your thoughts on what's next, let's say, and going beyond. So we do have some questions, and I will get to the first one. So the first one is, what's the starting dose of hydroxyurea you used, and what is the maximum dose?
Yeah, so I'm a pediatrician, so we do it on a weight-based. It's a little bit different in adults. But the key thing is it's 15 to 20 milligrams per kilogram is sort of the initial starting dose, and then we go up to 30, but sometimes we push it to 35 milligrams per kilogram, and that's and so I tend to do it in sort of the original studies did it in a very stepwise, slow progress. But I found that doing it, basically make sure they tolerated the low dose and then jumping straight to the higher dose. And that has been very effective in my practice. And I think you can get away with less blood work then, because you just need to follow things closely. I do blood work every 2 weeks at the beginning. And then after a month, if it's good, we then go to the higher dose and we do blood work. And then you can go, once things are stable, then you can go to blood work every 2 months. And if things are very stable over a year or so, then we can even go to every 3 months if things are very good. Because I'm trying to minimize the impact of this illness on the patients.
Great, thank you. Next question, why does the side effects of hydroxyurea include hair loss and sometimes infertility?
Right. Oh, and thank you. I didn't get into the infertility. The studies didn't talk about infertility because it's hard. It's a pediatric study. Infertility is way down the road. So we do know that hydroxyurea brings down the sperm count in men and males. The good news is that when you get to the age, where they want to have children, they can stop the hydroxyurea and the sperm count comes back up. We do know actually that sickle cell disease itself can have impact on fertility. So I think the flip side is not giving hydroxyurea you can have problems just from the sickle cell disease alone on hydroxyurea. So I think one of the problems we have is teasing out what problems are due to the disease and what is due to the medication, which is always a bit of a concern. And the hair loss, so the hydroxyurea, it can affect, because you know how it affects blood cell production, it also can affect the growth in your hair. Fortunately it settles down after the initial. So I find that in the first, it's 2 to 3 months, but I tell it, especially for young girls who they lose a bit of their hair and they kind of sometimes freak out a little bit, but I say, no, it'll settle down. So it does settle down, but that's just the mechanism of the medication, yeah.
Got it, okay. Next question, in case of toxicity, how can you titrate the dose of hydroxyurea? I think you teased on this in the previous answer, but maybe you can clarify it specifically.
Yeah, and that's always the challenge in this space is that when the blood counts, and so what I try to do is as little adjusting as possible that I can get away with. So for instance, I let the most common problem we see is what's one kind of white blood cell called the neutrophil count can go down, and I let it go down to even as low as the normal is 1.5 to 4 or 5. I let it go down to even 0.8 before I do adjustments. So and same with the platelet count, I let it go down to 80. So having a bit lower neutrophil count and a bit lower platelet count is acceptable. And so I try to avoid jumping on every little change that happens. And I might, if the counts have been good and it happens once, I might just repeat the blood work in a week or two and see if it stays down or if it's just a temporary blip. Because the blood counts can also come down if you got an infection. So very common, a child has a cold or a viral infection, their blood counts come down. So it's probably from that cold rather than the medication. And then so oftentimes you hold the medication if it's too low, and you hold the medication. And then if it's the first time it happened, I'll restart at the same dose and say, well, maybe it's just the infection. If it's happened a couple of times, then we'll say, okay, well, instead of going 30 milligrams per kilo, I'll be doing 25 per kilo, or and if it happens again, maybe to 20 per kilo. We know that being on hydroxyurea, even a lower dose, is still much better than not being on hydroxyurea. So I'd much rather have a patient on 20 milligrams per kilo of hydroxyurea than not. So that would be the one message I'd want to get across.
Great. Thank you, Dr. Klaasen. Next question. What is the longest going hydroxyurea study, ideally from childhood into adulthood, and what do the results look like?
Oh, yeah, that is great. And the problem with that study, which should be done, is that it's very expensive and difficult to do. And so very few, all these studies are only short-term studies. It's really quite challenging. So what often happens is people then revisit an old study and they say, try to collect as many of those patients who were in that study and relook at them 5-10 years later. And they've done that for some of the studies. But again, those are imperfect because the follow-up is incomplete. So you don't have, what you want is exactly what you said, is that baby hugs, all those 200 children that baby hugs, you want to follow them all the way through for 20 and 30 years. But unfortunately, the funding is not there to do that. But I think people try to do workarounds. And as I say, they try to see if they can track them down. But if they haven't been on a study for, those babies who were in that study back in 2011, if you haven't been keeping track of them, it's very hard to find them 10, 20 years down the road. So very difficult studies to do. I agree it should be done, but unfortunately it's very challenging. They don't get done, is the reality.
Great. Thank you, Doctor. Question here on what is the maximum fetal hemoglobin level that a patient on hydroxyurea can achieve? For example, 50% fetal hemoglobin and 50% sickle hemoglobin.
Well, I certainly have a number of patients who've got fetal hemoglobins in the 40s, which I think is wonderful, but that's the highest. I've never seen anybody who got made into the 50% range, but that would be fantastic. But I have most of the patients, if they're doing a really good job on their medicine, they're over 20% and ideally over 30%. But a few get over 40%. I don't think I've ever seen over 50%. But but interesting. I don't think we necessarily need to get that high to have a major impact. I know the studies in the original, before we were using hydroxyurea, even having a fetal hemoglobin over 10% had an impact on the long-term survival of patients with sickle cell disease. So even a little bit of fetal hemoglobin. But obviously the more the merrier. And I'm overall happy if it's over 20%, and I'm ecstatic if it's over 30, especially over 40%. I think that's very, very good. Yeah, I don't think you can make it over 50% on hydroxyurea, but.
Yeah, great. A two-part question. What is your experience using hydroxyurea in thalassaemic children? And can hydroxyurea help in keeping hemoglobin levels constant in thalassemia disease?
Yeah, no, that's a really interesting question. Because in thalassemia, it's a very different illness. And but you're right, you can increase it. The results have been mixed about using hydroxyurea. So it's not, nobody is advocating at this point in general using hydroxyurea in thalassemia, but there are specific cases, and I have on one or two occasions where I had somebody who their hemoglobin is down, but not low enough that they need to start blood transfusions, but I'm kind of concerned it's low, then maybe you can push, because if sickle cell disease is a guide, we know that the hemoglobin typically rises by 10 and many times 20. So the patient with sickle cell disease will start with a hemoglobin in the 70s, and they often go in the 80s, even 90s. And I had some over 100. So if you can get the same effect in thalassemia, you might have a patient who's floating with a hemoglobin in the 70s, which is not the greatest, and get them into the 80s, which is a better hemoglobin. But unfortunately, it's not nearly as clear cut in thalassemia.
Great. Next question. As a child, my crisis was very intense. However, thankfully, as an adult, I have been surprisingly well, 10 years crisis-free, and that's fantastic. My hematologist is advising me to still go on hydroxyurea, but I really don't see the need to since I've been doing good. My question is, why should I need to take it if I'm doing well?
Oh, wonderful. I love that. That's a great question. So I think many people have the focus in on the pain component of sickle cell disease, which is obviously has the most impact on quality of life. But in actual fact, that's not the thing that causes down the road, potential causes of death. And unfortunately, without any treatment in sickle cell disease, we know the studies have shown, and there's been very good studies that showed that the average lifespan of somebody with sickle cell disease with no treatment, again, they're older studies, but was for men in the sort of low 40s and women in the mid 40s. Again, I need to qualify, that was 20, 30 years ago. The healthcare is better, but still it's not a normal lifespan. So without any treatment, you're unfortunately not going to have a normal lifespan, which I don't think anybody is looking forward to, and that's on average. So some people die younger, some you could live into the 50s, it's possible you could live into the 50s. But it's not like you're going to, without any treatment, you're not going to live to be what a normal person's lifespan is, which is the 70s and 80s. So I just say, look at the alternative. If you don't go on hydroxyurea, you're going to, and there's really good studies now that show that there's lower patients on hydroxyurea have lower mortality, they live longer. So there's been a big shift so that the lifespan is now into the 50s for sickle cell disease, where it used to be in the 40s. And that's with people, hydroxyurea has only been in use in sickle cell disease in the last 30 years and really only in the last 15 years. So it's really only 15 years. So if you start when you're very young, I'm hoping that it'll be into the 60s, even the 70s. You'll have a lifespan going into the 60s and the 70s. Because that's a big difference. If you're in your 40s, you may be a parent of young children. That's devastating. If you're I'm in my 50s, my kids are moved out. So if I drop dead, it's not, I don't want to be facetious about it, but it's less important stage in life. Whereas, younger and you've got a parent of young children, that can be devastating. So I'd really encourage you to go on hydroxyurea. Don't just go by the pain, because there's other devastating effects of sickle cell disease that are not painful. Thank you.
Good. Thank you, Doctor. I know we've got 2 questions. What we're going to do is we're going to capture these questions. I know who sent them, or 3 questions. We will get back to you from the organization directly, but in the interest of time, so I know we are at the end of today's session. Just again, a big thanks to Dr. Klaasen and for all the audience and the questions, really engaging. Love it. But I want to make sure you guys all get back to the lobby so you can attend the next session. And that's back in our plenary.
The questions are amazing. Thank you.
Very good. So our next session is on the plenary Human Rights Equity for Individuals with Sickle Cell Disease panel. My colleague, Dr. Madeline Verhofstadt, will be moderating that. So I look forward to seeing you all back in the lobby. Thank you so much. Thank you, Doctor.